side is in a state of what? If this was in a state of external rotation, what's this rib in the state of? That's why you can't get air in on the left side. And the only way this air is going to get on this side is, what do you have to release on the right side, the contralateral side? What is that? Therefore, the subclavius is the next technique you're all going to learn. And once you get the subclavius technique down, Susan, all the ribs at that point should be able to what? Together. Now I got you. Life's pretty easy. This happens quite frequently. You do the technique that Chad we just did. We just got air on the right side. You guys did a great job. Now you're all sitting down thinking, wow, I'm glad that day's over. But your patient doesn't naturally just know how to shut off a subclavius if it's been tight for 30 years. Susan, you are a superior T4 patient. I'm going to show you. Susan, I didn't have the guts to tell you, but you can't get air in your left side right now. You're only getting in on the right. But wait till I show you what you can do on the left. I wouldn't want to go home just getting air on the right, because sooner or later she's going to go right back to where she was. Nobody released her subclavius. I didn't. That makes sense to a little bit? So I'm going to do a subclavius release on her right side so she can get air apically on both sides. So those arrows on both sides are going in the same what, Kurt? Direction. And now you can go run your 26-mile marathon that you think you can run without a first rib. Because the first rib, Jonathan, directs your entire rib cage. Now, do you need to do this on every single person? No. When do you need to do it? It's in the algorithm. You need to do it when, after you do a superior T4 manual technique, airflow is now limited on which side? The left side. Then you're going to do a subclavius technique, and then we can go home because you now know the major manual techniques. But we're not going to send you home yet. We've got to maintain that new position with some exercises. Otherwise, that superior T4 syndrome could come back. Does that make sense? And I'm making it sound hard. This is not hard. All you got to do is keep testing. Can they breathe? Can they breathe? And can they breathe? That's all we've done yesterday. Can you breathe? Can you get air in your right chest? No. I'll do a left AIC technique. He could breathe. What if he couldn't breathe yesterday? I would do a superior T4 technique. He can breathe. Okay, done. What if he couldn't breathe today? I would do what, Carrie? A subclavius technique. And now he can breathe. Guess what? There's nothing left you have to worry about. Maybe an intercostal wall on which side? Maybe a little pec work on the left side. Intercostal on the right, pec on the left. Maybe to enhance it. But the rib cage function has now been what, everybody? Restored. Your ability to do it has been given back to you. Now your ability to maintain it is questionable. If you don't pick a PRI activity from that 5-10-5 that's going to maintain it. Whew. Now we have it. That help everybody? And that's what you have in that diagram. The question is, Brianna, if you can't get air on that chamber right there, after I did what I just did, by holding which rib cage down? The right. And now you can't get air in on the left. You will do a subclavius technique, hopefully. And that's what we're going to do in this last part of the manual part of the lab.
Would all BC patterns have restricted airflow here?
No.
Even if the subclavius is holding it up in the BC pattern?
Yes.
But it doesn't do that in all BC
No.
patterns?
No. Some people have really easy moments after you get air in the right side. Things are clicking. All the ribs move pretty well
What about
together.
before any manual techniques?
It's possible that could happen. There are a lot of people out there that keep their shoulder function or are not in positions to use their subclavius and develop that first rib limitation. There are a lot of people who do not. The first rib is a king.
you know if they're not getting it, reading into their left?
How do you know if you're not getting air into the left? What would you do? Someone help her out. Good question, Stephanie. Love it. How would you know if you can't get air on the right? How would you know if you cannot get air on the right? What would you do? It's really, what would you do? Anybody? What's it called, Susan? On the left. I'm going to do a left apical expansion test for the right. Let's go to the other one. How would you know if you can't get air on the left? What would you do? You would hold which side down, Stephanie?
The right side.
Very good. You're going to know that. That's what we're going to do. Okay? And all of the things I just described to you are outlined on page 48. So I'm not going to read all of that. It's outlined on page 48. Heather, that's a reference for you. When do you have a right superior T4 syndrome? Can I use you, Stephanie? Why don't you read that out loud? Because that answers your question. When do you know you have a right superior T4 syndrome? Folks, remember, you have a superior T4 technique that is not reflective of a superior T4 syndrome. Then you have a superior T4 syndrome. What technique do you know that you have not done yet that Carrie told you you will need to do if you have a superior T4 syndrome? The subclavius technique. So it's on record. They're not the same. If you want to find out if you got a superior T4 syndrome, what would you do? Can you read it out loud for me, Stephanie?
When the patient has decreased left apical expansion, chamber 2, following a right superior T4 manual.
That answered your question. Now on page 49, what I wanted to take a few minutes on, and not a lot of time, is to show you the cross-section of the thorax that reflects a superior T4 syndrome. Does that make sense? So I want to just cut you, Stephanie, right through the right chest, breast area, and then cut you through right chest, and then the left. Open you up and look inside of you. In a normal person, you would see 5 ribs or 6 ribs laying parallel next to the subscapular region of the scapula. Do you see how these ribs are laying next to that scapula? Do you all see that? They're laying next to it. Okay. Whether it's one half of this cycle, whether it's this cycle or this cycle, those ribs and scapula need harmony, arthrokinetic harmony. If you have a non-pathological compensatory pattern, which is just a right BC pattern, I know it's a lot of verbiage, but just a normal right BC pattern, you're stuck in one rotational position. The ribs on the right side are all going to be in a state of internal rotation. We did that for the last day and a half. The ribs on the left side would be all in a state of what? External rotation. And you're stuck there. Don't lose this. You got it. We're stuck there. Arms are down, chest are down. Stephanie, right? We did that last day and a half. That's what that says. There's the spine of the scapula. That's the spine of the scapula. It's a drawing. We're going to get these drawings better, right, Jen? There's the scapula. There's the rib cage, and that's called rib torsion. That's okay. We'll call it rib rotation, but it's a little bit of torsion. Okay? Next slide. So on the next slide, here we've got a pathocompensatory pattern. A pathocompensatory pattern says you have a syndrome. It's called the T4 syndrome. And on T4 syndrome, on the right side, you have a few ribs that are in a state of what? Internal rotation, coupled with a few ribs that are in a state of external rotation. Stephanie, look where the contact is. Right there. Right there. That 4th vertebrae on that right side. Someone's going to come up to you someday and say, what can you do about that? Right there. It's nagging me all the time. Anybody in the room who's a real clinician will know that goes on quite a bit. Okay? Sometimes they'll say, do you hear this, Heather? Do you hear that? Do you hear that? Brianna, do you feel this? Just feel that. Feel that. You feel that? What do you think about it? Pretty cool. Huh? What are you going to do about that? And they take it away and they get really mad because now they can't do it anymore. It's a tick. It's a neurological tick. They love to show it off to you. It's a good party trick. Okay? Because they're landing right on that rib cage at that one angle. We just went over that a few minutes ago. It's called superior T4 syndrome. And on the other side, you've got the ribs that are going the other direction. They're going just the opposite direction. See, when one rib on one side of the vertebrae goes up, the other rib on the other side of the vertebrae has got to go what? Otherwise, you go into complete extension, you lock up. So we got ribs on one side going up now and ribs on the other side in the same line going down. And they're not all working together. That's patho. Can you say flat back? My goodness, look at this flat back on the right side. And the left side comes forward with it. Everything's flat. That's a superior T4 syndrome. So what's our goal in the superior T4 syndrome? To get these right ribs that are externally rotated, to say to them, listen, the collarbone was not made for it to hold you up the rest of your life. Who wants to tell me what the collarbone was really made for? Shoulder retraction. See, when the subclavius fires, the shoulder goes back. Remember today? How about this again? What was the collarbone made for? Thank you. Don't forget it. Okay? It wasn't made to guide and stabilize your arm. It was made to keep your glenoid from coming forward. So you don't look like this. Those pesky pecs. It was made for shoulder retraction. What rib is going to pull your shoulder blade in retraction? Number one. Because that's the only place that your clavicle attaches to for shoulder retraction. So you better have rib number one that can do what? What can it do, Chad? Rotate. Otherwise, you lose shoulder retraction. So, how are you going to keep that shoulder blade back? All the ribs on the right side have to work in synchrony, with all the ribs on the left side working in the same direction in synchrony. Otherwise, you have asynchrony, and then you have people walking up to you and say, Brianna, listen to this, baby. Like that? Do you feel that? Do you feel isn't that cool? Can you do that? Can you do that? Can you do that? Can you do that, Tyler? And I'm telling you because you know what? That's their reference. You have patients who are never going to go up there and say, can you feel that? But these are the same patients that say, you know what? I have to be there. You saw that patient, that one young woman walking. I have to be there, Linda. How was your weekend? I have to be there. That's where I have to stay. They may not be showing you why they're there, but they're telling you, I have to subconsciously be there. That's my reference. No one else is giving me a reference. And that's what that picture shows you. James Anderson, on page 50, did a good job talking about this thoracic rotation issue. And remember, the spinal movement provided by rib external internal rotation is huge if you're a spine person. Okay? I'm not having anything against spine people. But again, before I would look at a spine, I'm going to ask you one question. How are you? How you doing? Because if you're not breathing, you can work on that spine all day long. Those ribs are directing your spine, my friend, more than anything else you got going on in your life. And you can do something about that. So he did a phenomenal job at telling you what the ribs do with external and internal rotation in a left AIC pattern, which means your spine is oriented over to the right side.